So hello everybody, welcome back to the platform of Unacademy. And today is a very interesting session because we have pediatric quiz as a mixed bag quiz session. So we are going to discuss all the important MCQs, all the concept based MCQs so that we are thorough with the complete pediatric curriculum and we are confident before going to the exam. So all of those who would be listening to today's session, I request all of you to please participate actively in the quiz because it is to exercise your brain. Even if you don't know the right answer, you have some idea about it. You should be able to guess the right answer by diagnosis of exclusion, trying to recall, and whatever best that you can do. Many a time, even common sense helps you to make out the right answer. So it is very important for all of you to participate so that you keep understanding the topic simultaneously. And whatever basics that we can learn from here, we are going to start to see that also. So we have done a lot of MCQ marathons. So I hope that all of that has been useful because we have been discussing all these topics simultaneously, including neonatology and your pediatrics also. So I hope it is going to be helpful to all of you. Okay, so since people have started to join in, we'll start straight away with the quiz and the subscription part and everything I'll explain you later. Okay, so for those who have joined in, again, I request you please read the question carefully. Put in your responses in the chat box. Don't wait for others to respond. And whatever you think is the right answer that comes first to your brain, you have to respond to that. Okay, all right. Question number one. After a surfactant, after a surfactant therapy, the infant with respiratory distress syndrome, infant who has got respiratory distress syndrome is treated with continuous CPAP. So CPAP is given to a baby who is having respiratory distress syndrome. Which of the following is the major goal of giving a continuous positive airway pressure? So what is the role of giving a continuous CPAP to a newborn who has developed respiratory distress syndrome? Please start typing in your answers, everybody. Is it option number A to prevent infection? Option number B to prevent pneumothorax? Option number C to improve cardiac output? Or option number D to raise the arterial PO2 levels? So what could be the answer over here? All of you start typing in your answers. Those who are listening to the session, please exercise your brains a little more and come up with the right answers. ठीक है? Don't have to wait for others to answer. जो आपको सही लग रहा है, कैसे आंसर करोगे अगर एग्जाम में ऐसे क्वेश्चंस आते हैं? Okay, so one person has answered as option number D. Any other response from anybody? What could be the exact indication of giving a continuous CPAP to a newborn who has got respiratory distress syndrome? So respiratory distress syndrome में basically there is lack of surfactant. So lack of surfactant के वजह से what is going to happen? The alveoli can collapse. Alveoli can collapse at the end of expiration. Okay? So because of the collapse of alveoli, there is going to be CO2 retention. So to prevent that, we are going to give a continuous CPAP. So a continuous CPAP will keep this alveoli open and it will prevent its collapse during end expiratory phase. So it is going to raise the arterial PO2 values in the baby, which is the main problem that happens in respiratory distress syndrome. Okay? Is it clear to all of you? Those who are understanding the explanation and you're convinced, you can leave a thumbs up. If you were still thinking कि हाँ ये आंसर हो सकता है, मैंने मुझे आंसर कर देना चाहिए था. So if you think that the explanation is also right and you are okay with the question, then you can leave a thumbs up. Okay, so option number D is the right answer over here that all of you should understand. Okay, can we move on to the next question? Okay, question number 2. There's a full-term newborn who has got diffuse rash on the day of anticipated discharge. So आपने सारा काम कर लिया, आपने इसका discharge बना दिया, सब कुछ कर दिया, and at the time of discharge what happened? You diagnosed that the child has got erythema toxicum. Which of the following is true? It's a very simple question, just one basic concept behind it and you are done with the question. It is more common among term babies than preterm babies, usually associated with fever and a toxic state. It is uncommon before the 5th day of life. It is usually associated with an elevated peripheral white blood cells. So, which statement is correct about the condition known as erythema toxicum in a newborn? We have discussed this in the last quiz also in the dermatological manifestations of newborn. So, what statement is correct about erythema toxicum in a newborn? So, please start typing in your answers, those who are listening. Any more responses to those who are listening? Please type in your answers. Please rethink about the question. Erythema toxicum क्या होता है? Is it normal? Is it abnormal? What happens in this? Okay, so basically, erythema toxicum is a very normal skin finding that is present in term babies. ये बिल्कुल normal finding होती है. So it is basically seen in term babies and not in preterm babies commonly. It has nothing to do with any fever. There is no toxicity in the baby. It is absolutely normal and you can confidently discharge the baby also. ठीक है? It is uncommon before fifth day. No, that is wrong. It can be present immediately after birth on the first to second day also. It is usually associated with increased TLC. So ये सारे questions में ऐसे options इसलिए दिए हैं ताकि आपको confuse कर सके कि this is some kind of infection, but it is not. Please remember, erythema toxicum is a normal dermatological manifestation in a newborn, and you don't have to treat it. There is no toxicity, there is no increase in TLC, there is no sepsis setting. So what does become the right answer over here? Then you have to go for option number A, which is otherwise also right, that it is more common in term than the preterm babies. Okay, so option number A becomes right over here. There is no conditions of any sepsis, fever, toxicity, or increased TLC count. Is it clear? Please leave a thumbs up those who are understanding and you are okay with the answer. So it has to be an interactive class. I don't only want all of you to just keep guessing the answer. You should understand and also actively participate in the quiz. So those who are okay with the answer can also leave a thumbs up. Okay. So next question, question number 3. You're examining the chest X-ray of a 4-hour-old baby who was born at 30 weeks of gestation. The RR of the baby is 100 per minute, which is obviously increased, while breathing on 100% oxygen. You suspect that the baby has developed respiratory distress syndrome. What is the characteristic X-ray finding that you expect in patients who have RDS? ठीक है, very simple question. RDS के X-ray में क्या expect करते हो? What is expected in the X-ray of a respiratory distress syndrome? Is it option number A, having bilateral patchy densities and there is pneumothorax? Is it option number B, having diffuse reticulogranular changes and air bronchogram? Is it option number C, having diffuse aeration and cardiomegaly? Or is it option number D, having cardiomegaly and interstitial edema? So all options have been framed to confuse you, but it's very simple. RDS has classical reticulogranular changes and air bronchograms. Okay? Apart from this, there is no characteristic finding that is seen in respiratory distress syndrome. Nothing to do with pneumonias like patchy densities, nothing to do with pneumothorax. There is no hyperaeration or cardiomegaly or interstitial edema. So you have to go with option number B, that is diffuse reticulogranular changes and air bronchogram. All right. Okay. Question number 4. Which of the following system does the lecithin sphingomyelin ratio indicate the maturity for? LS ratio हम कहाँ पे calculate करते हैं to indicate which maturity? Please put down your answers in the chat box. Is it for central nervous system? Is it for lungs? Is it for liver? Is it for kidney? किसकी maturity check करने के लिए हम LS ratio calculate करते हैं? All of those who are listening, please start typing in your answers. Exercise your heads before the exam. Everybody should be typing in the answers. I feel that. So you should at least revise everything that you have studied by now. So it is option number B, that is lungs. So lungs की maturity क्यों check करनी है? Respiratory distress syndrome के लिए. So for that we have a very common thing that we do, that is use of LS ratio. Okay, question number 5. A 32-week gestation infant had progressive respiratory distress. A surfactant replacement therapy for RDS had to be given. Which of the following statement is true for giving a surfactant therapy? It is considered an experimental technique. It is only useful in infants whose birth weight is less than 1500 gram. It has not been shown to reduce mortality in very low birth weight infants. It requires tracheal intubation to administer surfactant. So, which is the true statement about the surfactant therapy which we give for respiratory distress syndrome? All of those who are listening, please think over the question. I've read out the options very loud and clear, so you can easily guess the answer also. RDS में surfactant therapy के बारे में, which is the true statement? Is asking the true statement, which is the true statement about RDS surfactant therapy. How do we give surfactant? Please revise your answers. Okay, so that is right. It requires tracheal intubation to administer. कैसे देते हैं? Ensure technique. What is ensure technique? It is intubation, giving of surfactant, and extubation. You just have to intubate the baby. You have to give the accurate dose of surfactant. You have to do the ambu so that the surfactant gets diffused out in the lungs. And after the whole procedure is done, you have to extubate the baby. It's not a lengthy procedure also. So it is always given by doing a tracheal intubation so that it directly goes inside the lungs. ठीक है? Experimental तो बिल्कुल भी नहीं है. That is the only treatment that we have. Only treatment that we have for respiratory distress syndrome. Only useful in children weighing less than 1500 gram. That is not the case. Body weight has got nothing to do with surfactant therapy. It is only the gestation age which is something to do with RDS and surfactant. ठीक है? जितना कम gestation होता है उतना ज्यादा रिस्क होता है रेस्पिरेटरी डिस्ट्रेस सिंड्रोम होने का, और जितना ज्यादा रेस्पिरेटरी डिस्ट्रेस सिंड्रोम होता है उतना ज्यादा एफिशिएंट होता है सर्फेक्टेंट थेरेपी. ठीक है? सो बर्थ वेट से कोई लेना देना नहीं है. इट इज टू डू विद gestation age. Has not been useful to reduce mortality in very low birth weight infants. So there's again nothing to do with the birth weight. It is all to do with the gestation age. And obviously, even if the birth weight is very low, then obviously the child is premature. If the child is premature, then RDS होने के chances बहुत ज़्यादा होते हैं. तो अगर आप surfactant दोगे तो obviously mortality would get reduced. So वैसे भी ये statement गलत है. This is also wrong. This is also wrong. So you're left with only option number D. अगर नहीं भी पता था तो भी आप आंसर कर सकते थे. अगर पता था तो पता होना चाहिए कि tracheal intubation करने के बाद ही आप सर्फेक्टेंट एडमिनिस्टर कर सकते हो. ओके, इज इट क्लियर? क्वेश्चन नंबर 5. क्वेश्चन नंबर 6. देयर इज अ हॉस्पिटलाइज्ड न्यूनेट was hospitalized. सबसे पहला इंडिकेशन is given the diagnosis of developing bronchopulmonary dysplasia. So BPD is another complication that occurs in newborn that you should be aware of. Which of the following best describes the pathophysiology of BPD? So एक hospitalized बच्चे में BPD डेवलप होने का सबसे important reason क्या है? Is it an inflammatory insult to the lungs late in the fetal development? Is it failure of development of pulmonary arterioles during early fetal life? Is it failure of development of the bronchial buds during the early fetal life? Or is it the use of oxygen and positive pressure breathing techniques in the treatment of RDS? So which of these treatment techniques or which of these causes can lead to development of bronchopulmonary dysplasia in a newborn? Very interesting question. I expect that you come up with the right answer. Any more responses? Question number 6. All of you please type in your responses for question number 6. What could be the right answer over here? Okay, so BPD is bronchopulmonary dysplasia. This is one complication that occurs in the lungs due to one important thing, that is increased oxygen exposure. So जिन बच्चों को आप प्री मेच्योरिटी टाइम पे बहुत ज्यादा ओवरफ्लो ऑफ ऑक्सीजन देते हो, उन बच्चों में दो चीज होने का बहुत इंपॉर्टेंट रिस्क होता है. रेपिटेडली इट हैज बीन आस्क्ड इन मेनी मेनी एग्जाम्स. एक होता है रेटिनोपैथी ऑफ प्री मेच्योरिटी और दूसरा होता है ब्रोंकोपल्मोनरी डिस्प्लेसिया. So these two are classical complications that develop because of hospitalization in newborns who are exposed to undue oxygen involvement or undue oxygen and continuous positive airway pressure. So जितना ज्यादा आप मैकेनिकली वेंटिलेट करोगे, जितना हाइपर ऑक्सीजन कॉज कराओगे, उतना ज्यादा रिस्क होता है न्यूबॉर्न्स में आरओपी और बीपीडी डेवलप करने का. So the right answer over here becomes option number D, that is use of oxygen and positive pressure breathing in the treatment of respiratory distress syndrome. Okay, is it clear to all of you? You can leave a thumbs up if you're understanding the questions. So this is medium difficulty level questions. We have already done two MCQ classes on simple one-liners. So apart from one-liners, you also get concept-based MCQs. So you should be very well versed with these kind of questions also. Okay? Question number 7. A mother has brought her infant. She is very concerned about a pigmented skin lesion present on the newborn. Which of the following is true of the pigmented lesion that is known as slate gray spots? This is a new question. You can just read out the options and try to understand if you are able to guess the right answer. I hope most of you must not have might have heard but not read about it properly. So you can just guess the answer out of this. They never occur in white infants. They are identified in over 40% of American African infants, matlab Asian and American both. Malignant degeneration is common. The most common site of occurrence is the nape of the neck. I just want anybody to guess the answer over here. अगर नहीं भी पता है, थोड़ा सा कॉमन सेंस लगाओगे, अगर आपने एमसीक्यूज प्रैक्टिस की, अगर आपको लैंग्वेज ऑफ क्वेश्चन समझ आता है, then you will be able to come to the right answer. Okay, any more responses? All right, so this is a new question and you should be aware of this. So slate gray spots are nothing but they are truncal spots which is present. They are present mostly on the back and to some extent on the extremities. So any statement that mentions all or never, 100% medical science में कुछ भी नहीं है. So never occur in white infants तो वैसे ही गलत हो गया. ये चीज तो हमेशा golden rule याद रखना. Never वाली चीज तो कभी सही होती नहीं क्योंकि 100% कोई भी चीज proven नहीं है. ठीक है. It is identified in over 40% of American African infants. तो ये हमें नहीं पता exact census क्या है, तो we can leave this option. Malignant degeneration is common. So malignant degeneration is something which can occur in serious skin infections. और जनरली जो चीजें न्यूबॉर्न में होती है, पिगमेंटेड स्किन लीजन एंड द मदर हैज ओनली ब्रॉट बिकॉज शी इज कंसर्न्ड. ठीक है. सो ऐसे कंडीशंस में अगर ये कंडीशन बहुत सीरियस नहीं है तो मैलिग्नेंट डीजनरेशन होना थोड़ा डाउटफुल होता है. सो बाय कॉमन सेंस मे बी यू कैन रूल आउट दिस ऑप्शन ऑल्सो. अब सबको यही कंफ्यूजन हो गई कि ऑप्शन बी सही है, ऑप्शन डी सही है. सो एनी स्पॉट्स that is usually present normally in a newborn involves the trunk or the back or the face. ठीक है. ट्रंक, बैक एंड द फेस. जितने इराइदेमेटस लीजन्स होते हैं वो सारे फेस पे होते हैं आपके. जितने भी ब्लैक ब्लू स्पॉट्स होते हैं लाइक मंगोलियन स्पॉट्स हो गया, ठीक है, एनी काइंड ऑफ हाइपोपिगमेंटेड लीजन्स, ऑल ऑफ देम आर प्रेजेंट ऑन द ट्रंक. So little bit if you have to choose wisely and you want to take a chance in exam, you might get questions like this which you don't know exactly the answer of this. So जब भी आपका 50% probability हो जाता है क्वेश्चन को सही मार्क करने का, then you should always mark it. So इसमें भी दो ऑप्शन हमने रूल आउट कर लिया. So we have 50% chance to mark it right. So by using this method of known as diagnosis of exclusion, you can still go for option number B, which is actually the right answer in this case. ठीक है. So this is a difficult question, so no problem. There are certain questions like this also in the exam to differentiate your rank with the toppers. So you can go for such question if you're able to exclude out two options correctly. Okay. Question number 8. There's a 35-week gestation infant delivered weighing 3.9 kg with an omphalocele and a very large tongue. No other abnormalities are detected in the baby. Which is the most likely diagnosis? So large tongue is a characteristic feature of one disease and omphalocele is also characteristic feature of one disease. दोनों को मिला दो, then which syndrome does it fit into? Start typing in your answers, everybody, those who are listening. Question number 8. Yes, it is classical for Beckwith-Widman syndrome. So Beckwith-Widman syndrome has got certain classical features. Large tongue एक बहुत ही important clue होता है इसमें, ठीक है? Unproportionate organomegaly is classically seen in Beckwith-Widman syndrome. So large tongue जहाँ भी सुनोगे, you can easily mark this. Omphalocele is also classically present as the ventral body defect that is seen in this disorder. Okay, so Beckwith-Widman syndrome is the right answer for this. Okay, question number 9. A 26-week gestation infant required intubation at birth. Which of the following is the pathophysiological mechanism of respiratory distress syndrome in premature baby? So very simple question. What is the pathophysiology in RDS? What causes RDS? That is all the question is asking you. Is it increased production of surfactant, decreased production of surfactant, increased metabolism of surfactant, decreased metabolism of surfactant? ठीक है, so respiratory distress syndrome क्यों होता है? It is because of pulmonary surfactant definitely, but what happens to the surfactant? Because the baby is premature, there is decreased production of the surfactant. So because of decreased production, the baby is not able to form enough surfactant that is going to lead to maturity of the lungs. So there is going to be decreased production, which will lead to presence of respiratory distress syndrome. Okay. Question number 10. A 30-week gestation infant with respiratory distress syndrome is getting weaned off from the ventilator. He currently has an oxygen saturation of 100% while breathing on 50% of oxygen on minimal ventilator settings. In a premature infant who has got RDS, which of the following may be an adverse effect of giving supplemental oxygen therapy? तो राइट नाउ आई टोल्ड यू अबाउट दिस इंपॉर्टेंट कंसेप्ट इन न्यूबॉर्न. सो काफी बार ऐसे होता है एग्जाम हॉल में जाने से पहले आपके बेस्ट फ्रेंड्स आपको कुछ ऐसा बता देते हैं जो एग्जाम में आ जाता है एंड यू फील दैट ही इज माय ट्रू फ्रेंड एंड द बेस्ट फ्रेंड ऑफ माय लाइफ. सो दैट हैज जस्ट हैपेंड विथ यू. आई ऑलरेडी टोल्ड यू द आंसर टू दिस क्वेश्चन. सो व्हाट इज द राइट आंसर? इट्स ओनली आस्किंग द एडवर्स इफेक्ट ऑफ गिविंग सप्लीमेंटल ऑक्सीजन थेरेपी टू अ न्यूबॉर्न. So we have seen that there are two important effects, that is ROP and BPD, that occurs in this condition. Agar ROP or BPD option mein, then you should go for it. So the answer over here is option number D, that is retinopathy of prematurity. Okay. All right. Next question, question number 11. So there's a healthy term infant who is getting circumcised. That means he's a male, obviously, and experiences excessive blood loss eventually, which required even transfusion. That means a lot of blood loss has been there. So what could be the most likely cause out of the following? So any disease in which there can be excessive blood loss because of circumcision, and the baby might require transfusion because of it. Any blood disorder, hematological condition that you can guess out of these, which is seen in males. Too many clues to help you diagnose this simple question. So what is the right answer over here? Okay, so because it is male and that's why they have hidden this term from here. That's why I wrote it over here so that you can guess that getting circumcised means that the baby is male. So had they not mentioned it clearly, you could have gone for other options also. But क्योंकि male है, newborn में hemophilia, that is factor 8 deficiency, is classically going to present as excessive bleeding. ठीक है, excessive bleeding to normal cuts or normal procedures that is done, like your circumcision is one point where these newborns get picked up because of excessive bleeding that does not stop. So the answer over here is going to be factor 8 deficiency, that is your hemophilia, and it is classically mentioned as male. So that is one clue that the examiner wants to give you to mark your answer as factor 8 deficiency. Okay, is it clear? Next question, question number 12. A newborn infant presents with cyanosis and mild tachypnea about 6 hours of life. The infant is therefore placed in 95% oxygen and saturation normalizes. Which of the following is the most likely diagnosis in this infant? Please read the question carefully. These are all concept based questions. You have to be very careful before putting your answer. It is actually a very common condition that is seen in term newborn babies. So that is why they have mentioned cyanosis is there, tachypnea is also there, and the hours is 6 hours of life. So term newborn may any condition that leads to cyanosis and tachypnea in the initial few hours of life. You can guess that. That is very clear. We are talking about transient tachypnea of newborn that occurs in term babies. So what do we do? If the baby is cyanosed, we need to put on a supplemental oxygen. But if we give oxygen, then the saturation immediately normalizes. So that means we are talking of TTNB and not of any cardiac condition. Had it been a cardiac disease, we would not have found a normal SpO2 after giving oxygen supplementation. So it is a lung disease that is characteristically transient tachypnea of newborn, which will get normalized after some time once the baby has washed off the interstitial edema and there is no fluid accumulation in the lungs. Okay? So that is what is going to happen in this question. So you see the question has been framed. First you have to think about the clinical condition and then you have to guess the disease also, the management part, and then you have to see that what is happening after giving the treatment. So these kind of questions are very, very important to understand. You can get any kind of these questions in the exam. Okay. Question number 30. There's a 3-week-old infant who is noted to have microcephaly, cerebral calcifications on the skull X-ray, and also blindness. Which of the following is the most likely cause of these findings? So, in which infection can you see presence of microcephaly, intracerebral calcifications, and blindness? So, all the nerve disorders accumulated with your calcification in the brain is seen in which condition? Very simple question. So session is little long because I'm trying to revise the whole of pediatrics through the MCQs so that you guys are very comfortable with the exam, and also to those who are preparing seriously for the next attempt can get an idea about how the questions are framed. So the session is as long as 50 questions. So if anybody gets bored in between and don't want to continue, you can text in the chat box. We can take a little break or we can reschedule the half of the session later on. But those who are interested into solving, you can keep continuing with the questions. Okay? So I'll ask you your responses when we do 25 questions. So all of them are concept based MCQs. So all of you should be open with your minds and ears. Listen to the question, think about it, and then type in the answers. Okay? So anybody feels anything, you can start sharing in the chat box. I don't want to stress anybody before the exam. But these are very beautiful questions. Most of them have been asked in the exams in one way or the other. Some of the questions I have framed myself out of my own clinical practice. So it is just to test your concept level before the exam. Okay, so nothing to worry. It's very simple questions. It's not at all difficult. So cytomegalovirus is the right answer over here. Congenital CMV infection, if it has occurred, it can lead to hydrocephalus, it can lead to microcephaly, it can lead to cerebral calcifications, and it can affect the nerves, causing auditory and visual problems. So that is all that can occur in cytomegalovirus. Chorioretinitis is classical. So all of these are features of CMV infection. Is it clear to all of you? Okay, so next question number 14. There's a 7-day-old infant who develops white, cheesy patches on the tongue and buccal mucosa, and there is mild inflammation of the mucosa as well. Which of the following organism is most likely the cause of these white oral lesions? So, which organism causes white oral lesions in newborn or in any human? White oral lesion is classical for only one infection. What is the answer to question number 14? Yes, the answer is option number A. That is a simple fungal infection, and most likely it is Candida that leads to oral thrush. Okay? So oral thrush is one condition which can occur normally in newborns also, and oral thrush occurs normally in other age group people also, and everywhere it is a white cheesy appearance on the tongue and buccal mucosa with little bit of inflammatory changes in the mucosa which can occur. Okay? So that is the answer as Candida albicans. Okay? So any doubts you can keep posting. I will clear all the doubts towards the middle break that we take for the session. So right now let's focus on the MCQs. So if there's the genuine doubt right now regarding the answer, then we can discuss. Otherwise, there might be many doubts in everybody's mind. So you can keep typing it in and we'll discuss it as soon as possible. So question number 15. There is an irregular red reflex which is noted on the initial examination of an infant. The infant is referred to the ophthalmologist for evaluation of the cataract. Which of the following is the most likely associated disease with a cataract in a newborn? So if you get cataract in a newborn, what could be the underlying disease in a newborn? Many times this question has been asked in one way or the other. So please mention the disease in which you find classically cataract in the eyes of a newborn. Any more responses? Yes, so the right answer is galactosemia. Okay, so it is most commonly associated with one condition, that is galactosemia. Okay, galactosemia में one other important question that comes, which is the important cause for causing sepsis in a newborn. So the answer to that is E. coli. Okay, question number 16. An infant has got congenital club foot. Which of the following system is most commonly involved with this disorder? Please think about it. किस condition में club foot is one congenital anomaly that is associated with many systemic complaints also. It can be a part of some syndrome as well. So which of these systems is most commonly involved if a person has got congenital club foot? What could be the answer over here? Please type. All those who are listening to the class, I request you to please exercise your brain and start typing in the answers. Okay, so the right answer is CNS. So congenital clubfoot is commonly associated with CNS disorders. It is to do with the lower limbs. वैसे भी guess कर सकते थे जो CNS disorders होते हैं like your brain and spine. In that generally the lower limbs also get affected. So if you did not know the exact answer, then you could still guess it. GIT से क्या लेना देना clubfoot का? CVS सोच सकते हो, but then clubfoot is something which is congenital anomaly which occurs because of problems in the posture of the baby when the baby is in utero. That is one reason. So if there is oligohydramnios also, it can lead to such problems. So oligohydramnios can also be associated with a lot of neurological manifestations as well. So the position of the baby in utero is one important factor, and neurological manifestations are commonly associated with all the lower limb complications. Okay? अगर spinal problem है, neural tube defects है, any kind of meningomyelocele, all these lower limb problems are associated with your CNS disorder. So you can easily guess it that way. And those who knew the exact reason, so that is also very nice. So like that, you can guess the option number A, that is CNS. So कभी give up नहीं करना होता किसी question पे. Just use your common sense a little bit what the question is demanding, and so you should be able to answer it. Question number 17. There's a term otherwise healthy baby neonate who has been isolated with premature synostosis of the sagittal suture. Which of the following is the most likely associated condition? So this is again a new question. Those who have studied all the problems in the sutures and the fusion problems in the bone, you can answer this. This is a little difficult question, but still those who know can put in the answers in the chat box. Okay, those who are listening to the video with so much difficulty because it's a revision class. So all of you, I request that you can attend the class, either the recorded version or this. It's going to be helpful anyways. So it would be good if you attend it live so that you're able to see what people are responding and what you're responding. So the answer to question number 17, any more responses anybody wants to give? This is a new term or a new question that has come up. So if somebody has read it, okay, so the right answer is option number A, that is scaphocephaly. Okay, so you should read about it. If not, you can just remember it for your exam. This means basically a long and ovoid kind of a skull that is present. So it is actually long because sagittal suture ki has isolated synostosis of the sagittal suture. So this gives to a shape which is known as Caphocephaly. ठीक है, there is nothing to do with increased ICP. There is nothing to do with microcephaly or hydrocephalus. So अगर नहीं भी आंसर पता होता, so we all know that the cephaly terms are used for abnormal fusion of the brain sutures. So that could be the answer. अगर wild guess करना चाहो तो भी guess कर सकते हो. Otherwise, if you know the exact term, it is more than enough to answer in the exam. Okay. All right, question number 18. A newborn infant has got micrognathia, glossoptosis, and cleft palate of the soft palate. These findings are consistent with Peary-Robin sequence, as we all know. Which of the following is the life-threatening event that is associated with Peary-Robin sequence? So one thing that can occur in Peary-Robin sequence patients, which could be life-threatening in them, because it has already mentioned what is present, so it's very simple to answer this question. So what is the answer over here? What is the complication that can occur if there's Peary-Robin sequence in the baby who has got small jaw with a tongue? What can happen to the tongue? So in this condition, if there's a small jaw and the tongue is over there, which is going to fall back, it can lead to upper airway obstruction. So upper airway obstruction can lead to sudden death as well. Okay? So this is a life-threatening situation which is seen in Peary-Robin sequence. Alright, so I'm glad that most of you have come up with the right answer to this question. So next question, number 90. There's a newborn infant who gags and chokes with feeding. He has just had an apneic spell during the feed which resulted in significant cyanosis. Which of the following is the most likely diagnosis? It's a very simple question if you read it properly. Any newborn infant who is gagging and choking only after giving the feeds, and because of the feed he has also gone into apneic spells which has resulted into cyanosis. So what could be the most likely diagnosis in this condition? Only common sense is required to answer this question, so please type in your answers, those who are listening. Okay, so it's very, very simple to understand. So if this proximal esophageal atresia, what will happen? So because of this, there is abnormal communication between the esophagus and the trachea, known as tracheoesophageal fistula problems. So in TEF or in complete esophageal atresia, what is going to happen? The child will have frequent choking and regurgitation of the feed, and that will lead to cyanosis only post feeds. So only post feed cyanosis is present. So anything related to the feed, if asked in the question, you can guess that they are talking about tracheoesophageal fistula or esophageal atresia. So that is a very classical indication to understand what the examiner is demanding. If they had anything to do with the heart, if you were thinking about hypoplastic left heart syndrome or any other cardiac condition, that could not be the option, right answer, because there's nothing to do with the feeds. If there is any underlying cardiac illness, then obviously it is going to have constant onset of cyanosis, and there won't be improvement in the cyanosis as well. So choking with the feeds means there is something to do with the pulmonary part. So that has got abnormal communication with your pulmonary tract as well. Okay. Question number 20. A family history of seizures is present in both the mother and maternal grandfathers. During examination, the infant you note has got a skin finding that is associated with the family history of having seizures. So, newborn with skin finding is present that is related to having sudden onset of seizures. So any disorder which is genetic, any disorder that runs in the family, any disorder which is related to some dermatological manifestation, which you can guess the disease and mark the right answer for question number 20. So I've already taken 3 MCQ classes which were based on your simple one-liners. So NEET PG exam is not only about having very, very difficult questions. They can check you on simple concepts also. So you get a mixed question. So that is why I've taken different sessions. There were 3 sessions which have been taken. So you can recapitulate from there. There are simple one-liners also where you don't have to use your brains too much. If you know the answer, you can mark it right. So you can go and listen to that session as well. And we have concept based MCQs also, where you have to understand the concept and then mark the answer. So these are also not very difficult questions. These are simple questions, but it only tests your application in the examination stress. So you'll get a mixture of question in a NEET PG exam. So today we are discussing all the concept based questions. Okay. So you can also revise the difficult one-liners from the other pediatric MCQ marathon that I've taken on newborns and also simultaneously on pediatric MCQs. So the right answer, we are talking about tuberous sclerosis. So we mean that they are speaking about the hypopigmented patch that is present in the newborn. Okay. Okay, next question. There's a healthy newborn who is noted to have many 3 mm vesicles on the chest and the neck, along with several similar sized hyperpigmented macules in the same distribution. Which of the following is the most likely diagnosis? So please remember the question is asking the first thing that is very important. It is a healthy newborn. Okay. So healthy newborn में ऐसा क्या हो सकता है? Where you have hyperpigmented macules and you have vesicles all over the body. Please read the question carefully, exercise your brains, and then tell me the right answer. It is a healthy newborn. First thing, there is vesicular lesion. Vesicles are present on the chest and the neck. Nobody is mentioning any developmental lines or any specific distribution. And wherever the vesicles are present, they also have got hyperpigmented macules. There is no hypopigmentation. There is classical vesicles. That means active lesions are present with hyperpigmentation. So how can you go for option number C? Any other option that you would like to choose? Even if you don't know the exact answer, you can try to use the method of diagnosis of exclusion. So you can rule out the options that is not definitely the answer, and then you can arrive at the right answer. So even if you don't know the exact answer, because dermatological part in newborn is also complicated, so there's nothing to do with acne neonatorum in this condition. Many of you must be thinking about herpes simplex infection, but then having active vesicles in a healthy newborn, that is not the right thing. So if the newborn is healthy, obviously you cannot expect the baby having active herpes infection, so this goes out. Then there's most confusion between option number C and D. Okay, so incontinentia pigmenti में सबसे important चीज होती है hypopigmentation is the first thing that is going to be present in the newborn age group. So ये hypopigmentation तो दिया नहीं है question में, so that also goes out. And second thing, the distribution is mentioned. It is present anywhere on the chest and the neck. And you also have similar lesions, which are hyperpigmented macules in the same distribution. So, incontinentia pigmenti का classical feature क्या होता है? That is present on the lines of development. So that also helps you to rule out this option. So, अगर आपको नहीं भी पता था कि इसका आंसर ऑप्शन नंबर डी है, that is transient neonatal pustular melanosis, you can put the answer rightly. Mark the option right as option number D confidently, because you have actually ruled out all the three other options. So this is the classical example how you use your common sense by diagnosis of exclusion to arrive at the right answer. So कभी भी कोई question पढ़ के अगर नहीं पता उसके बारे में, don't give it up, because even if you make few questions like this right, your rank is definitely going to shoot up in the exam. ठीक है? So D is the right option over here. तो हेल्दी न्यूबॉर्न्स में whenever you get important terminologies like this, थोड़ा सा दिमाग यूज किया करो. हेल्दी वर्ड क्यों दिया है? They want to say that the baby is not toxic, so you cannot go for any active infection as the cause. Okay, is it clear to all of you? Do you understand the meaning of the question and why these questions are framed like this? Okay, so next question number 22. There is a 40-year-old couple who comes for genetic counseling prior to having their first child. They are very much concerned about the advancing maternal age and the possible genetic problems it could cause to their child. Which of the following is the most likely disorder associated with advancing maternal age? So, which kind of genetic problems is associated with advancing maternal age? So, what is the concept? If you have read your syndromes properly and you know the pathophysiology, वहां से भी guess कर सकते हो. अगर पूरा genetics पढ़ा है तो वहां से भी guess कर सकते हो. अगर नहीं पढ़ा है तो अपना दिमाग लगा के common sense से भी guess कर सकते हो. So I think all of you can mark this option right. There is nothing so difficult in this question. Advancing maternal age से कौन सा problem होता है जिसकी वजह से genetic syndromes develop होते हैं? Yes, it is Down syndrome. So अगर Downs का mechanism पता है तो भी आंसर कर सकते हो. It is option number B, non-disjunction of the chromosome. That is the problem that occurs with advanced maternal age. ठीक है? So अगर maternal age advanced है, so what is going to happen? You will have non-disjunction non-disjunction of the chromosomal disorders at the time of mitosis and meiosis. So that will lead to the problems in trisomies or any other kind of problem, for example, Down syndrome. Okay. Okay, next question is also very interesting. So, if you know that advancing maternal age can lead to these problems, can you tell me what will happen if there is advancing paternal age? So, same concept applies. If any disorder, if the 40-year-old couple has come and the father is concerned about his age, what disorders can occur in the baby if there is advancing paternal age? So you should be aware of this also, क्योंकि maternal age तो बहुत बार आ चुका है, so maybe you can get paternal age as well. Please type in your answers, everybody. So this is a completely new question. So let me guess. Let me see how many of you are able to guess it right. Guess work भी बहुत बार काम आ जाता है एग्जाम में. So I'll give time to think over this question. Anybody wants to answer it? Advancing paternal age can lead to which kind of disorders? So I have knowingly put this question so that you guys become aware of this. It is going to lead to autosomal dominant disorders. Okay. All the autosomal dominant disorders are most commonly inherited due to advanced paternal age. Okay, please get your concepts clear over here. Maternal age में सिर्फ non disjunction की problem सबसे ज़्यादा high होती है. But if there is advancing paternal age, you get all the autosomal dominant disorders. अगर यहाँ पे X-linked dominant होता instead of only X-linked disorders, then there could have been a confusion. Then I would prefer to go for X-linked dominant. But अगर autosomal dominant है option में, then please go for autosomal dominant disorders. Okay, clear हो गया सबको? So the answer to question number 23 is option number C, that is autosomal dominant disorders. Okay. Next question, question number 24. Which of the following best describes the way to differentiate between cephal hematoma and caput succedaneum? Is it absence of history of prolonged labor? Is it present in both or not? Is it limitation of swelling to the area of the bone that it covers? Is it having a normal neurological examination or a prolonged prothrombin type? So which factor can you use to differentiate whether the baby has the swelling because of cephal hematoma or caput succedaneum? So many a times while doing MCQs, you come across new questions also. So it is not that your exam will have all the questions that you have read till now. There can be certain new questions also. So it's better you get to hold of these new concepts before you enter the examination hall. Okay. So what is the answer to question number 24? How can you differentiate between cephal hematoma and caput succedaneum? Okay, I think everybody knows the answer. It is limitation of the swelling to the area of the bone. Okay, so caput succedaneum is basically just because of the pressure of the instrumentation that we use, and cephal hematoma is because of the accumulation of the blood. Okay, so history of prolonged labor is present for both. Neurological examination is normal in both, and prolonged prothrombin time is nothing to do. There can be hemolytic jaundice in cases of cephal hematoma. Okay. Hematoma is the blood swelling that occurs. That's absolutely right. So, cephal hematoma and caput succedaneum are two very important topics. Okay, question number 25. There's a normal newborn who is screened for hypoglycemia. So, in an asymptomatic term neonate, evaluation and treatment of hypoglycemia should be initiated when your blood glucose is at or below which of the following levels. So, simple question: what is the cutoff of normal RBS in a term baby? What do you consider as a normal RBS or glucose level in a term baby? It's not the last question of the evening. There is another set of 25 questions. So, what is the cutoff of normal RBS in a newborn? So it is 40 milligrams per deciliter. ठीक है, 40 से नीचे है, and if the baby is symptomatic, then you will start to treat. So please remember another very important concept from here. IV dextrose is only given if the baby is symptomatic. That means having seizures, is lethargic, having poor sensorium. Otherwise, in any other condition, whether it is infant of diabetic mother or any other condition, you will only give oral. You're only going to continue with exclusive breastfeeding. Okay, breastfeeding is a very nice method to maintain euglycemia in newborns. Okay, so please don't mark IV dextrose in any of the options until and unless the baby is critically sick. Okay, everything revolves around exclusive breastfeeding. That is going to correct a lot of problems. 45 is the cutoff that we use in failure to thrive babies or those who have severe acute malnutrition for the treatment. 40 is the exact cutoff that we use for RBS in term newborns. Okay. Any other doubt? Okay, so we have done 25 questions. So anybody who wants to continue with the quiz for another 25 questions so that you finish off all the pediatric MCQs today? So between 40 and 45, there's a lot of confusion. So to be more specific, 45 is the exact value that we use for the plasma value of RBS. Okay. So if you have specific terms like this, you can go for 45. But if you are asked only the normal glucose levels, which is the cutoff for treatment of hypoglycemia, then the answer is 40 milligrams per deciliter. ठीक है, अगर कोई प्लाज्मा पूछता है आपसे क्लियरली इट इज 45, अदरवाइज इट इज 40, क्योंकि होल ब्लड और प्लाज्मा में डिफरेंस होता है. ठीक है, सो इतने हाई लेवल क्वेश्चंस आपसे नीट पीजी में नहीं पूछे जाएंगे. दीज आर नीट सुपर स्पेशलिटी क्वेश्चंस, सो यू कैन जस्ट कंटिन्यू रिमेंबरिंग द बेसिक कंसेप्ट्स. ओके, all right, so those who want to continue, do you want to take a break or you want to continue? Because another, these were the 25 questions that we have from neonatology, and next 25 is mixed bag clinical MCQ from your pediatrics. Okay, so you can take a break, Dr. Ajit, and when you're freshened up, you can join back or you can listen to the recorded version as well. Okay? All right, question number 26. There's a 7-year-old boy who arrives to the clinic with the chief complaint of having fever and left facial swelling. Okay? The mother reports that 2 days ago, the area around his left eye had become red and swollen. He denies any history of insect bite and trauma. Upon examination of his left eye, you note that it is markedly swollen and the upper and the lower lids are swollen with proptosis, and there is limitation of the movement of the eye. So what is the clinical condition they are describing? And the sclera is also hyperemic. What is the next step in the management? Okay? The question is very simple. It is just trying to check your patience of reading the question and the examination stress. So 7-year-old boy has come who has got massive swelling of his left side of the eye associated with little bit of facial swelling. There is proptosis, limitation of movement of the eye. So this condition is known as what, and what is the treatment? Yes, it is orbital cellulitis. So how do you treat it? What option would you go for? Will you tell the parents nothing is wrong and please go back? Would you just do the CBC, blood culture, give antibiotic and follow up in the clinic? Would you do ocular antibiotics only for 7 to 10 days, or would you admit the patient and start proper doses of IV antibiotics? So the best option to choose over here is option number B. You definitely need to send CBC to see the increased TLC counts, that is the onset of sepsis, blood culture sensitivity, because many times you can get the isolate if the infection is disseminated. Okay? And then you have to start antibiotics, which could be IV definitely, but then IM is given over here, that is not a big problem. So antibiotics need to be given up, especially you use third generation cephalosporins. Okay? So third generation cephalosporins have a very broad coverage, so you can use that. And after the patient is treated, you need to follow up in the clinic also to see any complications of orbital cellulitis that has led to vision abnormalities. Okay? So that is the answer of this question. It is very simple question. Orbital cellulitis mein we have to rule out sepsis and we have to treat the baby with IV antibiotics. Okay. Question number 27. While examining a patient, you find a discrete whitish polyp that extends through the tympanic membrane in the child who has history of recurrent otitis media. Which of the following is the most likely clinical condition that the question is asking you? So if you find a whitish kind of discrete membrane or a polyp that is present in the tympanic membrane, what is that clinical condition known as? Whitish discharge or whitish coloration from the tympanic membrane with recurrent otitis media. बार बार otitis media होने से क्या हो जाता है? It is cholesteatoma. ठीक है, cholesteatoma is pearly white lesions that we see. ठीक है, so pearly white lesion जहाँ भी mentioned हो, you have to think about cholesteatoma. That is also because of recurrent otitis media that is occurring. Okay. So cholesteatoma is the right answer over here. You can also cross check it with your ENT notes, but I think cholesteatoma is definitely the right answer. So you have to go for that. Question number 28. There's a 20-month-old child who is brought to emergency department because of fever and irritability, refusal to move his right lower extremity. Physical examination shows that he has got a swollen and a tender right knee, which resists any passive motion. So he's not able to move his knee at all. Which of the following is the most likely to yield in the diagnosis of the patient? So first you have to recognize the condition that they are talking about, and once the condition is recognized, how will you do one test which can help you to diagnose this clinical condition? Refusal to move his right lower limb, excessively swollen and tender right knee, not able to move on passive motion. What test would you do to diagnose this condition in one go? Yes, it is septic arthritis. That's right. Very good. So septic arthritis may basically there's a lot of swelling and tenderness over the bone, which will not allow the passive movement also. So if you do a pus aspirate examination of the fluid over there, that is going to help you aid in the diagnosis. So the right answer is option number A. You can also send the culture of the fluid. You can also see the increased level of cells and the counts that is present inside the joint fluid aspiration. So that becomes one diagnostic method to be very sure you're dealing with septic arthritis so that you can start IV antibiotics to kill the organism. Okay, so that is the right answer to question number 28. Okay, question number 29. There's a mentally retarded 14-year-old boy who has got a long face, has got large ears, has got micro penis and a large testes. Chromosomal analysis would demonstrate which of the following. So which syndrome is being talked about over here? And if you do the chromosomal analysis, what would you find in this condition? What is the answer to this question? It's a very classical syndrome which is repeatedly asked in the exam. So long face, large pinna, micropenis and a large testis. That classically with mental retardation fits into Fragile X syndrome. So that's very good that you marked it right. Fragile X syndrome is one classical condition which has got all these features. So the answer is going to be option number D. Okay. Question number 30. There's a 2-year-old boy who's brought to the emergency room with complaints of fever for 6 days, development of a limp. On examination, you're seeing that he has got erythematous macular exanthum on his body. He has got conjunctivitis, he has got dry and cracked lips, there is red throat and also cervical lymphadenopathy. Too many clues to make you realize the question answer right now. His hemogram also shows thrombocytosis. Later on, he starts to develop peeling of the skin in the soles, which is the most likely diagnosis that we are talking about. So all of these fits into one classical clinical condition. What is it? Please put down your answers, everybody, those who are listening. So we all know that there's a classical condition of a vasculitic disorder that involves the multi-system involvement, that is Kawasaki disease. ठीक है? So Kawasaki disease में सारी चीजें बहुत important है. Fever for more than 5 days is very important. Then you find all these findings like a non-purulent conjunctivitis. There is dry and cracked lips. So all the mucosal parts are going to become dry. They can be cracked. They can get peeled off. There is redness of the throat that is classical presentation of pharyngitis. There is cervical lymphadenopathy as well. And on CBC, you have increased platelet counts. Okay? So that is classically known as thrombocytosis. And after this, there is peeling of the skin in the sole. So all of this fits into a classical condition known as Kawasaki disease. So on 2D echo, if you do, there's one complication that occurs, that is aneurysm. So you are going to find the aneurysms of the middle-sized arteries. So that is one complication that is also asked from Kawasaki disease. And what is the treatment of choice? It is IVIG therapy. Okay, so IVIG you have to give, which is the treatment of choice for this clinical condition. Okay, so question number 30, the answer is Kawasaki disease. Question number 31. 8-year-old girl presents to you with well-controlled, moderate persistent asthma. Her therapist consists consist sorry her therapies consist the use of short acting beta agonists, daily inhaled steroids, and a leukotriene inhibitor. Now she has presented to you with simple white patches on her buccal mucosa. What would you recommend to this patient? Get an HIV test done, measurement of the serum immunoglobulin levels, discontinuation of all the asthma medications, or you would ask her to rinse her mouth and then clinically examine again. So what is the answer to question number 31? It's a very simple common sense question which anybody can guess because the asthma treatments include the inhaler. So what could be the answer? Yes, the answer is option number D. Because of these inhalers, because it is steroid, so it can lead to deposition also in the oral mucosa, buccal mucosa, and it can also lead to candidiasis if it is for a prolonged duration of time. So you can ask the child to rinse the mouth and then you can again examine it to see whether it is the side effect of the inhaled medication or the child has encountered some kind of infection. So HIV testing is not needed because it is because of inhaled steroid. Immunoglobulin is not needed because we are not talking about primary immunodeficiency disease, and you cannot discontinue the inhalers in asthma treatment. So you can just diagnose whether it is because of inhalers or is it because of any onset of recent infection. So you will ask her to rinse the mouth and re-examine the baby. Okay? Next question number 32. There's a 6-week-old child who arrives to you with complaints of fast breathing and cough. On examination, you note that the child has no temperature elevation. The respiratory rate is 65 breaths per minute and oxygen saturation is 94%. There is no temperature elevation. Okay, the physical examination is significant for findings like rales and rhonchi. So chest में आपको rhonchi मिल रहे हैं. The past medical history of the child is positive for presence of eye discharge at 3 weeks of age. Which of the following, for which she was treated with topical antibiotics? So which of the following organism are we talking about in this clinical condition of the child? Eye discharge along with pneumonia, classical combination for only one organism. What could be the answer to question number 32? Please type in your responses, those who are listening to the class. Eye discharge with pneumonia in a newborn or an infant is classically only because of chlamydia trachomatis. Okay. So chlamydia is one thing which classically presents with sticky eye discharge. Okay, sticky eye discharge is there, and also it can lead to atypical pneumonia. So do you see how the question has been framed? The question is telling that the baby has got fast breathing, but there is no elevation in temperature because it is a viral pneumonia. So that might not present with classical toxic features like high temperature, but the respiratory rate is 65 per minute. That means the stress is present and her saturation level is also only 94%. Physical examination is significant that the child has got rales and rhonchi in the chest and also has got history of having eye discharge at 3 weeks of age. So neonatal age group mein, you should always remember chlamydia is one infection that can lead to atypical pneumonia and also has got sticky eye discharge clinically. So if that is the combination, then it classically fits into option number D. Okay. Question number 33. A 5-year-old boy was brought to pediatric emergency with sudden onset of respiratory distress and noisy breathing. So distress is also there and there is noisy breathing as well. His RR was 64 per minute. On auscultation, you find there is decreased air entry on the right side of the chest. On confirming the history, it was found that the child was playing with his siblings and has had sudden difficulty in breathing. The X-ray has been shown, so kindly analyze the X-ray and choose the likely diagnosis. Is it pneumonia? Is it fungal sepsis? Is it foreign body aspiration? Or is it pleural effusion? तो चेस्ट एक्सरे में क्या दिख रहा है? कैन यू सी द डिफरेंस इन दी both the sides? So there is hyperinflation on one side. Unilateral hyperinflation is classical finding seen in only one condition, which most of you have already marked it. That is option number C, foreign body aspiration. So there is unilateral hyperinflation of the lungs, and especially if there is foreign body aspiration, it is going to have findings on the right side of the chest. Okay? So the answer is going to be foreign body aspiration. Another clue, 5-year-old classical presentation, preschool and school going children में होता है ये. 4 to 5 years classical age for foreign body aspiration. Also the question mentions that he has got noisy breathing. That is another important clue. And he was playing with his siblings. So while playing, many a time children can take peanuts or pen cap or any foreign body inside their trachea. So that can lead to foreign body aspiration. Fungal sepsis, you will have fluffy opacities, which is classically present. Fluffy opacities will be present, sparing the paracardiac parts. Paracardiac involvement agar hota hai, that means if you find the opacities only in and around the cardiac regions, that is classically for pulmonary manifestation of worm infestation. ठीक है, तो parasites का अगर manifestation pulmonary part में complicate हो रहा है, then you will find paracardiac fluffy opacities. ठीक है, if you're finding fluffy opacities everywhere in the chest, which is like ball-like lesions, then that could be a fungal sepsis also. It could also be a manifestation of underlying malignancy in the body. So if it is fungal sepsis, you will find ball-like fluffy opacities all over the lung field. Okay. Question number 34. A 2-year-old child regularly regurgitates the food that and then rechews it and reswallows a part of the feed. Regurgitation begins within a first few minutes of feeding and lasts for about an hour. The parents are very frustrated with the child. The child is at the 5th percentile for the weight and has lost weight over the last 2 months. There is no other past medical history. Physical examination is also unremarkable. So what is the best management at this point that you will give? तो अभी मैंने pediatric psychiatry का revision class लिया था. If anybody has listened to that class, you would also easily know the answer to this question. So we are talking about rumination. So what do we do in rumination? What is the answer to question number 34? All of you, please put down your answers, those who are listening. Question number 34, what is the right answer? Please think over it. Even if you did not listen to pediatric class, I mean psychiatric class, so you can still rethink about it. 2-year-old child regularly regurgitating the food. Regurgitation begins few minutes and lasts for about an hour. The parents are frustrated with the child and the child is having weight loss also for last 2 months, but there is no other significant past medical history. That means the child has not complicated any time. The physical examination is unremarkable. So even if you read the question carefully, what is the best management that you would choose? So if you again ponder about this question, you would know कि कोई systemic complaints नहीं है and the child is not toxic. So you can only give behavioral therapy because they are talking about one behavioral abnormality seen in children known as rumination disorders. ठीक है, so rumination disorder में we can do nothing, we can only give behavior therapy. So that is the answer. ठीक है, pediatric psychiatry is also very very important. It can be asked in the exam. So if you want, you can just go back and listen to my YouTube class that I've just taken half an hour before on pediatric psychiatry illness. So that will help you guys revise psychiatry illnesses very very fast. Even if you have not read before the exam, that much of lecture would be very much sufficient for you to revise it. Okay. Alright, question number 35. An 18-month-old infant is brought with the contents of bottle of drain cleaner in his mouth. So somebody has taken the bottle of drain cleaner and he has swallowed some amount of it. Which of the following is the most appropriate steps in the treatment? So if any child comes as an MLC case in the emergency department by swallowing toilet cleaner or drain cleaner, then what is the most important step that we have to do? Which option would you choose for question number 35? So toilet cleaners and everything is acidic basically. So if you have read your accident and emergency, जब भी acid ingestion होता है something we avoid. You don't want to injure the mucosa all the more. अगर mucosa और भी injure हो गया, it can lead to perforation. That becomes a medical emergency to operate. Do you want perforation? Absolutely no. So if you induce immediate emesis, what will happen? Whatever things that have settled will again go back and erode the mucosa. So it can again lead to complication of perforation. So immediate emesis is absolutely wrong. Endoscopic examination within the first 12 to 24 hours is the right option. So endoscopic evaluation is a must to do if the child has ingested any amount of acid. Why? Because you want to determine the mucosal injury that is caused. ठीक है? कितनी mucosa injured हुई है? Do we need to operate or not? What is the grade of injury? Everything is done with endoscopic evaluation, and it is classically indicated that it should be done within the first 24 hours of the ingestion itself. Okay? Decontamination by activated charcoal is now not advised in acid ingestion because it does not absorb the acid and it can also lead to further mucosal injuries. Okay? So please don't mark this option. Activated charcoal has got no role in decontamination of an acid ingestion. Neutralization by drinking a solution of opposite pH. This is also not done. Acid ingestion does not get neutralized with any kind of solution. It is going to slowly get absorbed, and just to prevent maximum absorption, we advise intake of simple oral sips of cold fluid or any kind of liquid item that we can give. So very simple oral sips of cold items are given so that the child does not have more of mucosal erosions in the GI tract. So we cannot give any drink solution which has opposite pH. That has got no role. Decontamination by activated charcoal is out of scene now, and immediate emesis is highly contraindicated because it will further lead to mucosal injury in the child. Okay, so please don't choose any of these options whenever the question is talking about acid ingestion. तो एसिड इंजेक्शन का सबसे इंपॉर्टेंट चीज होता है म्यूकोजल इंजरी को प्रिवेंट करना. ओके, इज इट क्लियर टू ऑल ऑफ यू? नेक्स्ट क्वेश्चन नंबर 36. Yes, pesticide ingestion में where you have the solid items, there you can use the charcoal to absorb the toxic amount of whatever insecticide or pesticide that the child has taken. In acid ingestion, you don't have to give anything to absorb it. You just have to prevent it from moving here and there so that it does not cause any mucosal injury. Okay. Apart from these, any other insecticide, pesticide, or cleaners like not cleaners, your rat poisons or anything which is taken, there you can use this activated substances which can absorb the poison from GIT. But in acid ingestion, you don't have to do any lavage. You don't have to move the baby. You don't have to give any kind of emesis inducing things. जितना भी मूव करेगा आपका एसिड उतना ज्यादा म्यूकोजल इंजरी होगी. ओके, so that would be the answer now. Okay, question number 36. Physical examination of a 3-day-old boy shortly after birth reveals a large bladder and palpable kidneys. Avoiding cystourethrogram has been shown here. It appears to be otherwise, the child appears to be otherwise normal. Which of the following is the most likely diagnosis? So can you identify this image? Does it resemble anything? Can you guess the clinical condition in this picture? Okay, first option they have given it is boy, that means male disordered hai. At birth only there's large bladder and a palpable kidney. Voiding cystourethrogram is done. Otherwise the child is normal and not toxic. So what could be the diagnosis? So this looks like a keyhole, right? Doesn't it resemble like a key? So this is the classical thing which is seen in patients of posterior urethral valve. So PUV is a very common condition that can be diagnosed in the newborns right at the time of birth. So this is the presentation. Obstruction ke wajah se there's dilatation of the proximal part. So because of this dilatation, it presents like this. So this is known as a posterior urethral valve. Okay. It is not any kind of obstruction or prune belly or duplication of the collecting system. So this thing is seen in posterior urethral valve. It is classically seen in a male newborn baby who presents with palpable bladder, large bladder and large kidneys because of this obstruction. Is it clear? So the answer is option number B. Okay, question number 37. There's a 7-year-old boy who has got cramping abdominal pain and rashes as shown in this figure. So can you see this kind of elevated palpable petechial rashes that is present? It is mainly present on the back of his legs and the buttocks as well as the extensor surfaces of his forearm. Laboratory analysis shows that he has got proteinuria and microhematuria. In addition to this rash and pain abdomen, which other clinical finding do you think would be classically associated with this condition? So what is the condition we are talking about? And one more clinical finding that is very commonly seen in this clinical condition would be chronic renal failure, arthritis, seizures, or unilateral lymphadenopathy. So we are talking about HSP, that is henoch-Schönlein purpura. So HSP में classically bone pain or arthritis is very commonly present. So presence of rash, presence of pain abdomen and presence of arthritis or arthralgia is classically seen in HSP. Okay, so that is going to be the answer over here. Is it clear to all of you? Simple questions, clinical based questions are very simple to understand and also mark the right answers. So next question number 38. On examining the back of the child, you see what is shown in this figure. So what is this? This is tuft of hair. Okay, tuft of hair is seen. Which of the following statement about this child's condition is true? So if you find tuft of hair on a baby's back, what clinical condition can be associated with this? Please think about this question, then mark your answers. So tuft of hair indicates what problem? And if that problem is present, then what could be seen? Please read the options and then think about it. Can it be associated with flat foot? Is there hypertrophy of the lower limbs? Can it be hyperreflexia of lower limbs? Or there can be frequent UTIs, which is common. So it's a little difficult question. Okay, so tuft of hair is present. That basically means there is some kind of spinal abnormalities. Most commonly, it is associated with spinal dysraphism. ठीक है, जो स्पाइनल कॉर्ड पूरे अच्छे से क्लोज नहीं होता, there can be problems in the spina bifida part. So spinal dysraphism is a broader term that is used, which can be present, and the external finding that we see is the tuft of hair. So if the spinal dysraphism is present, the lower extremities do get affected, but there is going to be hypotrophy, not hyper, hypotrophy or atrophy of the lower limbs. There is hyporeflexia of the lower limbs. So these options go out. Flat foot has got nothing to do with it. It is another problem which is because of bony abnormality. And there's frequent UTI infections, which is common. So in these patients, they have a lot of frequent urinary tract infections if they have abnormal findings like spinal dysraphism, which presents with tuft of hair on the skin. ठीक है, यूटीआई बहुत कॉमन होता है बिकॉज ऑफ डेवलपमेंटल और एनाटॉमिकल एबनॉर्मैलिटीज. You can remember this correlation. It can be asked in any form. Because of this anatomical abnormality, they have frequent urinary tract infections. So any baby who's presenting with tuft of hair, you have to rule out all the causes associated with spinal dysraphism. Okay? Is it clear to all of you? Please leave a thumbs up, those who are understanding the session. Okay, so let's move on to the next question. Question number 39. A 5-month-old child was normal at birth, but the family reports that the child does not seem to look at them any longer. That means eye contact is gone. The child also seems to have startled response more easily as before. He also has got poor attainment of the milestones. So which of the following could be the most likely cause? So very simple question. Startle response किस में दिखता है? Along with mental retardation, lack of eye contact. Okay, so I'm glad most of you are still awake with the MCQs. So we have another 10 MCQs, but all to help you use your brains and not sleep. So you can easily enjoy doing these MCQs. Startle response is a classical finding that is seen in only one condition. इसमें मिलता है startle response. Any more responses? Startle का मतलब क्या होता है? Hyperacusis. Means if you have a loud noise that the baby is going to get a startled response. It's a very classical condition. Any other responses? So it is a very common thing which is seen in Tay Sachs disease. What is Tay Sachs disease? It is GM2 gangliosidosis. So if you haven't read metabolic disorders, very commonly asked in pediatrics. So if anybody has time, you can go and listen to my lectures on metabolic disorder, part 1, 2, 3, and 4. So that will cover all the lysosomal and glycogen storage disorders, and it would be clear to all of you. So GM2 gangliosidosis, mein we have two things. We have got Tay Sachs disease and we have Sandoff's disease. Okay. Tay Sachs is caused due to hexosaminidase A deficiency and Sandoff में A और B दोनों होता है. ठीक है. So this is one question again which keeps coming. Tay Sachs disease में you get very important things. One is your startle response, that is your hyperacusis. ठीक है. Then you also get, apart from hyperacusis, you get cherry red spots on examination of the macula. The cherry spots are also found in your Tay Sachs disease, and mental retardation is also present, and you have lack of eye contact. Okay. So 5-month-old baby is a classical presentation for Tay Sachs disease. It classically presents in less than 1 year of age. So 5 to 6 months is the classical time when the baby starts to develop these symptoms. Okay? Cherry red spot, startle response, hexosaminidase A deficiency, lack of eye contact, and presentation at 5 to 6 months, later on leading to mental retardation, and the child dies by 2 to 3 years of age. That is the course that you need to know about Tay Sachs disease. So in short, you can remember these golden points for Tay Sachs disease. ठीक है, clear हो गया सबको? Where else do you find cherry red spot? So apart from GM2, you also find it in GM1 gangliosidosis. So please remember Tay-Sachs, Sandoff, and GM1 gangliosidosis. All these places you are going to find cherry red spots. Okay, question number 40. About 12 days after a mild upper respiratory tract infection, a 12-year-old boy complains that he is having weakness in his lower extremities. Over several days, the weakness progresses to also include the trunk. On physical examination, he has the weakness described and no lower extremity deep tendon reflexes are elicitable. There is muscle atrophy or pain. Spinal fluid studies are done, which is going to show you elevated protein only. There is no increase in the TLC count, which is the most likely diagnosis of the patient. Okay, so the child had got upper respiratory tract infection. After that, he developed weakness in his lower extremities. The weakness is now progressing from lower part to the upper part of the body, and there is no DTRs which is elicitable. There is no muscle pain and muscle atrophy. And spinal studies show that there is only increase in protein, that is albuminocytological dissociation. So this classical clinical condition is talking about which disease? Is it Bell's palsy, muscular dystrophy, Guillain-Barré syndrome, Charcot-Marie-Tooth disease? Which option would you go for? Question number 40. Yes, so all of these fit into one classical condition known as GBS, Guillain-Barré syndrome. So this is all that happens. Ascending paralysis is there. There is onset of 1 to 2 weeks before any kind of respiratory tract infection or kind of loose stools, which can lead to some viral exposure. So after that, what happens? There is ascending paralysis. It starts with sudden onset lower limb weakness, progresses to trunks, diaphragm, respiratory weakness, bilateral upper limbs, changes in the voice. There would be no DTRs wherever the effect has happened, and muscle atrophy would also not be there. There will be no sensation abnormalities. Bladder bowel is not affected in GBS. It is going to stay intact, and the treatment of choice is to give IVIG course. Okay, albuminocytological dissociation is present classically if you do the CSF analysis. Okay. All right, question number 41. There's an infant who develops infantile spasm. The image given below shows a dermatological manifestation associated with the disease. So there is some kind of lesion on the skin. Which of the following disorders is most likely to be seen in this infant? So again, we are dealing with one dermatological manifestation and features of infantile spasm or seizure. So we are talking about which condition? So we have already done one question like this, so it's very simple. We are talking about pneumocutaneous syndrome, in which we see this ash leaf macule. So what is ash leaf macule? It is a hypopigmented lesion that is present on the trunk part of the baby. So it is a case of tuberous sclerosis. Alright, that's great. Question number 42. An 18-month-old child presents to the emergency department with a brief generalized tonic-clonic seizures. He is now post-ictal and has a temperature of 40 degrees Celsius, so very high grade fever. Lumbar puncture done was normal. He also had got large watery stool which had got both blood and mucus in it. Which of the following is the most likely diagnosis? So which organism leads to dysentery plus CNS involvement? Only one organism causes this classical presentation. What is the answer to question number 42? Yes, the answer is shigellosis. So, shigellosis is one classical condition in which you find CNS manifestations along with dysentery. So, shigellosis is not very common now, it is rare only, but you should know that if they're talking about CNS manifestations, that means the patient develops seizures, then you have to go for the option of shigellosis. Okay. Question number 43. A 8-year-old sickle cell patient arrives at the emergency room in respiratory distress. Over the previous several days, the child has become progressively tired and pale. So the child is developing gradual onset of pallor. Once you do the hemoglobin levels, you find it is 3.1 milligram per deciliter. Which of the following viruses would you likely isolate in this picture? So which is the organism that causes sudden fall in the RBC or causes red cell aplasia in a patient whose hemoglobin can fall as low as 3.1 milligram per deciliter? What is the answer to question number 43? So the organism that causes red cell aplasia or sudden fall in the RBCs is parvovirus B19. So parvovirus B19 is commonly seen in sickle patients who have sickle cell anemia as well, and in otherwise healthy individual also. If they get parvovirus B19, it is going to lead to sudden onset of severe anemia. Okay, so that is the right answer. Question number 44. There's a 16-day-old infant who presents with fever, irritability, poor feeding, and a bulging fontanelle. Spinal fluid shows that it has got gram-positive rods. Please be careful, it is gram-positive rods. Which of the following is the most likely diagnosis? Yes, so most of you are answering everything right. I'm very glad for today. So please answer question number 44. Then we are left with another 5 questions only for this extensive quiz. The gram-positive rods in a newborn causing sepsis and meningitis is only one, that is Listeria monocytogenes. Okay, so if you see this image, if they don't mention rods, please be careful. If it is elongated and like rods, don't go for streptococci and everything. It is obviously Listeria monocytogenes, that is gram-positive rods. Okay, so that becomes the answer to question number 44. Clear हो रहा है सबको? Question number 45. There's a 2-year-old child who is seen in the emergency center with a 10-day complaint of having fever and limp. So, fever is present and the child is also having limping episodes. The ESR is as high as 60 per hour and the radiograph is shown below. So, can you see the arrow is showing something in the bone? Kind of a swelling over here. Which of the following statement about the child's condition is correct? It is most commonly caused by Streptococcus pyogenes. It can arise following development of deep cellulitis. It usually results in diffuse tenderness. It does not require antibiotic therapy. Okay? So the X-ray, because I'm sitting over here, it's not visible. So the X-ray basically just shows a localized swelling in the bone. Okay? So what condition is it talking about and which statement is true about this clinical condition that we are discussing? So we are dealing with which condition? It is osteomyelitis. Okay, so osteomyelitis may which condition out of these statements seems to be right? So it is caused by Streptococcus pyogenes. No. Does it lead to diffuse tenderness? No. It is localized tenderness of the bone. Okay. Antibiotic therapy obviously we have to give. So the right option over here is option number B, that is it can arise following a deep cellulitis. So any sepsis setting in a child can lead to infection spread in the bone also, which can lead to osteomyelitis. So how does it spread? It spreads by hematogenous route. So because of the hematogenous spread, because of any infection that has already occurred in the child, it can lead to hematogenous spread and that can cause infection, that is osteomyelitis in the bone. Is it clear? So the right answer is option number B. Question number 46. A mother reports that her daughter has got a 3-day history of subjective fever, hoarseness and a bad barking type of cough. Okay? So this is classical presentation of for which disease? And upon examining this child, you would expect to find which of the following. Fever with hoarseness and barking cough means what? And what is the clinical condition? And what is the right option to that clinical condition? So the right answer here, all of you, those who are listening, still awake, please type in the answers. So the right answer is option number C. It is talking about parainfluenza virus. We are dealing with croup. Okay? So barking type of cough, cold, hoarseness, and fever. That is classically for croup, and it is caused because of parainfluenza virus. Okay, that's absolutely right. Question number 47. 2 weeks after a viral syndrome, a two-year-old child develops bruising and generalized petechiae, more prominent over the legs. There's no hepatosplenomegaly, very important. There is no HSM or lymph nodes in the child. The examination otherwise is unremarkable. Laboratory testing shows that the patient have got a normal hemoglobin, hematocrit, and WBCs and differentials also. But the platelet count is 15,000 per microliter. Which of the following condition are we talking about? Isolated thrombocytopenia. One clue to help you reach to the answer. Along with palpable purpura and petechiae all over the body. So what is the condition that we are talking about? If the child has got only thrombocytopenia, all the rest of the red blood cells and the WBCs are normal and has got generalized petechiae and bruising after an infective episode, we are classically dealing with idiopathic thrombocytopenic purpura. So we are talking about ITP in this clinical condition. Okay. All right. That's clear to all of you, I think. Question number 48. There's a healthy 1 year old child who comes to you for a routine checkup and for immunization. His parents have no complaints or concern. The next day, you do a CBC just for routine examination and you see that the percentage of eosinophils on the differential is very high as 30%, which is the most likely explanation. So again, mark the words. They are talking about a healthy baby who has come for routine examination. Accidentally on CBC, you see that the eosinophil count is very, very high. So what could be the reason for this manifestation? Which option would you choose? Is it bacterial infection? Is it allergic rhinitis? Is it fungal infection? Is it helminthic infestation? So increased eosinophilic count is very, very classical for which condition? Especially in India. So because they are talking about healthy child, that is one very important condition that you should ponder about in the question. So it is helminthic manifestation. If there is worm infestation, the child can remain healthy also. Yes, the answer is option number D. So worm infestation with the child can be healthy and the eosinophil count can be as high as 30% also because of the eosinophilia that is occurring because of worms. So you have to deworm the child. You have to give albendazole tablet 400 mg start dose. Okay. So that is how you manage worm infestation in our country. So helminth infestation is the right answer for question number 48. Second last question. A 10-year-old boy is admitted to the hospital because of bleeding. The laboratory findings include that the platelet count is 50,000. The prothrombin time is 15 seconds, which is increased as compared to control. The APTT is also 51 seconds, that is increased than the control. Okay? The thrombin time is also mildly deranged. Factor 8 level is 14%, whereas normally it should be 38 to 178%. Which of the following is the most likely cause? So those who are hearing carefully and जिनके दिमाग अभी तक खुले हैं, you can easily answer this question. It is a little tricky question, but please see the question carefully and choose wisely. Don't rush into the answer. It is not that simple question. 10-year-old boy had a bleeding episode. उसके प्लेटलेट्स भी कम है, प्रोथ्रोम्बिन भी डिरेंज्ड है, एपीटीटी भी डिरेंज्ड है, थ्रोम्बिन टाइम भी डिरेंज्ड है, फैक्टर 8 level is also less. So with all this, it fits into which clinical condition? So don't rely only on factor number 8. Please see the other parameters as well. Okay, so I know the confusion lies to choose hemophilia A, but if you read the question carefully, can't you see there is absorption of all the clotting factors? All the clotting factors कहने का मतलब फैक्टर 8 इज लो, तो अगर फैक्टर 8 लो है क्या मतलब है कि वो हीमोफीलिया ही हो सकता है? नो, इट कैन बी DIC. DIC क्यों? क्योंकि देयर इज ब्लीडिंग डायस्थेसिस, द चाइल्ड इज ब्लीडिंग, यस द चाइल्ड इज ब्लीडिंग इज गिवन इन द क्वेश्चन. प्लेटलेट्स आर गेटिंग कंज्यूम्ड, क्या हीमोफीलिया में डिक्रीज प्लेटलेट काउंट होता है? नेवर. ठीक है, प्लेटलेट्स आर डिक्रीज्ड plus you have absorption of all the clotting factors, that means your factors are also getting reduced. You have altered coagulation profile. ये सारी findings कहाँ मिलती है? DIC में. PT is also deranged, APTT is also deranged and thrombin time is also deranged. क्या ये सारी derangement हीमोफीलिया A में होती है? हीमोफीलिया A is to do only with APTT time. ठीक है, so अगर प्रोथ्रोम्बिन टाइम भी अफेक्ट हो रहा है, थ्रोम्बिन टाइम भी अफेक्ट है, APTT भी अफेक्ट हो रहा है, प्लेटलेट्स भी कंज्यूम हो रहे हैं, सारे ब्लीडिंग सारे कोएगुलेशन फैक्टर्स कंज्यूम हो रहे हैं, देन दैट क्लासिकली फिट्स इनटू डिसेमिनेटेड इंट्रावास्कुलर कोएगुलेशन और DIC. ठीक है, प्लीज रीड द क्वेश्चंस केयरफुली बिफोर आंसरिंग एंड चूजिंग, और राइट ऑप्शंस चूज करना तभी सही होता है इफ यू रीड ऑल द ऑप्शंस आल्सो केयरफुली. जैसे ही देखा कि फैक्टर 8 कम है, you shouldn't go for hemophilia A because that is not exactly the right answer. You should see platelet count भी कम हो रहा है, PT भी कम है, APTT is also deranged, thrombin time is also getting deranged. So all of this fits into DIC and you have it in the option. So why to mark hemophilia A? Okay. Yes, D dimer would get raised in this condition, right? So that is the exact answer, option number C. The last question for the day, and it is a simple question. A 6-month-old infant has been exclusively fed on infant formula. Once the child gets introduction with fruit juices, the child develops jaundice, hepatomegaly, vomiting, lethargy, irritability, and seizures as well. Tests for urine reducing substances are positive. Which of the following is the likely clinical condition we are talking about? ठीक है, फ्रूट जूस देने के बाद the child becomes symptomatic. Which is the condition that we are talking about in which the child cannot digest the glucose or the fructose that is present? So we are talking about which clinical condition? Hepatomegaly, jaundice, vomiting, irritability, seizures, lethargy, all of that occurs because of hereditary fructose intolerance. So reducing sugars become positive in the urine. Okay, so hereditary fructose intolerance is diagnosed when the child is weaned off from top feeding or infant formula feeding to other items that contains fruit juices or anything which contains fructose. Okay, so please remember, jaundice in a newborn, there are 3 important differentials that you get questions from, and it is very commonly asked in the exam. One is your fructose intolerance or fructosemia. You also get on galactosemia, which we have already solved. And then you have a classical presentation of tyrosinemia. ठीक है, वो सारे option दे भी रखे because they know children get confused. So don't get confused. Fructosemia में liver failure होता है, but they have reducing substance as positive. Galactosemia में you would get clues like cataract, E. coli, sepsis. ठीक है, liver failure can also be present. Tyrosinemia में you have got boiled cabbage like odor. ठीक है, boiled cabbage odor is classically seen in tyrosinemia. Plus you have got your liver failure presentation. ठीक है, so liver is affected and also you have got boiled cabbage like odor. So that is all key features that you see in these disorders. Alpha-1 antitrypsin deficiency में you see recurrent history of jaundice. You won't find it for the first time. There is a recurrent history of jaundice that is present in alpha-1 antitrypsin deficiency. Okay, so is it clear to all of you? Please leave a thumbs up those who enjoyed the quiz and you felt that it was informative and you guys enjoyed it, and it also made you feel confident that you could solve all the 50 questions in the test. So thank you all of you for listening so patiently, being so actively participating in the quiz. My chat box is full with responses, so it makes me feel also very good because I designed this quiz especially for your exam purpose. Yes, that is the enzyme deficiency that is present in tyrosinemia type 1. Okay. So please stay calm. Do not panic for your exam. I hope all of you do wonders in the exam and everybody will come up with the flying colors. So all of you should stay calm at this last minute. Just revise whatever you have read. Keep doing MCQs. Keep attending the revision sessions that we educators are taking, because that is very informative, consolidated, and will help you revise and refresh all the parts that you have studied till now. The Bugs Bounty is one special feature that is present in Unacademy. You can report any inappropriate content as well. If you have not started to follow Telegram channel, please follow by the name of Let's Crack NEET PG, so that you can get all the updates about our classes and all the important sessions that we are taking. Now, for those who are interested to learn pediatrics from me on Pediatric Plus classes, so you can use my code Kavita S10 and unlock the session for special classes to get a free access to all the special class. And also you can use this code to buy the plus subscription. So this month I'm going to finish pediatric cardiology and pulmonology. So those who are interested to study these units from me, all in all, right, starting from the developmental, all the disorders and the complication, so everything would be complete. So if you want to study it from me, please take the plus subscription, use my code to unlock it. And if you do that, you can meet me on the plus hours, where we are going to finish all the units one by one. So I'll be taking all your pediatric classes, neonatology, social pediatrics, all the national health programs in children. So that will complete your entire curriculum of pediatrics. So I would request all those who are interested, please start taking the plus subscription, because I'm starting the classes very soon with all these important units this month. So you can be a part of it, and I promise that you could finish these units very nicely. If you want to listen to a sample lecture, you can listen to cardiology that I've taught on YouTube. So if you like the way of teaching, if you like the mnemonics, the word association, the tricks that I use, so please unlock my code and start taking the plus hours for a short duration of time. Also, you can try it, and if you like it, you can extend it for 12 or 24 months plan. Okay, so we have this iconic and plus subscription with us. So those who want to start taking the subscription, please start subscribing. You can log in and take the subscription for at least 48, 36 or 24 months duration. Whenever you do it, please use my code Kavita S10. If you put down this code, you get 10% instant discounts on your packages, and that is going to be financially fruitful also. So we still have 12 plus 2 offer running. So those who want to take it, you get additional 2 months discount, 2 months free access to your course. We have a 4-year subscription plan for all the MBBS batches. So you can use this. Again, you can use my code to unlock it. That is Kavita S10. You get additional 10% discount. So I hope this grand test was fun for all of you and must have performed wonderfully. So all the educators have been proud. And then we have the grand test series. All of those who have not started to take, please start taking the grand test, so that you get a feeling of appearing in the test before you go for the main exam. So the 1 month package that was running is still valid. You can take it and use it for the grand test and the critical analysis and the MCQ discussion batches. For iconic subscription, a word I would like to tell, it is a combo subscription and by far the best selling subscription from Unacademy. So all of those who want to study seriously for the exam, please take this iconic subscription. You would also get additional notes under iconic subscription. Those who are taking only plus subscription, you would be valid for taking the notes only till 11. So अगर 11 से पहले आप plus subscription लेते हो, you will get the benefit of taking notes also. And if you take it beyond 11th, you have to subscribe for the iconic. So under plus, you get all the benefits, and also you avail the benefits from prep ladder. So plus subscription is the most basic subscription we have, but still you get a lot of benefits like live recorded class. You get to learn from top educators. You get to compete in live tests and quizzes. You can study from device of your choice. You can access 25,000 plus questions, and you also get the handy set of notes to easily revise the topics that we have taught you. So please come and take the plus subscription. Use my code Kavita S10 so that you can use it for taking 10% discount, and I can teach you pediatrics to the best of my possibility. So this month we are finishing cardiology and pulmonology. So those who are interested, please come and subscribe. Thank you all of you for listening so patiently. I think it was a fun class, and I think all of you enjoyed answering so many questions. So we'll meet up soon again with the most common series in pediatrics. That means we are going to discuss all the most common things in pediatrics, like most common disease, most common syndrome, most common cause, most common X-ray finding. So all these kind of questions will be jotted down together for having a fast revision. So I'll soon announce the class. Most